Hello again, everyone. I am going to do a couple of lectures for you today as part of Unit 1 in Biology 202. And the first one, I'm just going to use this one PowerPoint for both, but I'm going to split it up. First one will be about the cardiac cycle. Those are the events that lead to and cause one heartbeat and the movement of the blood in that one-way direction through the heart chambers that you've been learning about already. You know, what has to happen at a physiological level for one heartbeat to occur. That's your cardiac cycle. And we'll also talk about the heart sounds as well. And I should have here on the title of the slide that we're going to talk about cardiac output as well. So I'll have to correct that a little bit later. All right, let's get started here. Bring up the old trusty pen. Alrighty, so let's start talking about the cardiac cycle. So as I mentioned already, the cardiac cycle includes all of the events associated with one heartbeat. One heartbeat is one cardiac cycle. So what has to happen to make one heartbeat occur? Now, you've already heard about the electrical activity through the heart as part of the cardiac conduction system and how that works and how the electrical impulse that's generated within the cardiac conduction system, starting at your SA node, spreads across the muscular walls of the atria and then later across the muscular walls of the ventricles. And you've already learned about your heart valves and seen some of that in the anatomy side of the course, I hope. And then you had a nice lecture from Mark Brannon about the EKG, the electrocardiogram, which gives us a representation of this electrical activity around the heart that stimulates contraction of the muscular walls. So we're going to go into a little bit more detail here and just kind of I'm going to walk you through how all these things coordinate together to cause one single heartbeat and also to ensure that that blood is flowing in the correct direction through the heart, like you're learning in the lab part of the class with your blood tracing. A couple of terms here in case you have not heard them already that I'll be using here: systole and diastole. Systole refers to contraction, diastole refers to relaxation, and you've no doubt heard these derivations of these words used before: systolic and diastolic blood pressure. Systolic blood pressure is the higher blood pressure number when your blood vessel walls have the most pressure in them, and your diastolic blood pressure is the lowest blood pressure reading when your blood vessels have the lowest amount of pressure in them. And that story will occur here with the heart as well. When the atria or the ventricles of the heart are said to be contracting, that is systole. If the walls of the atria or the ventricles are in a state of relaxation, they're not contracting, that is referred to as diastole. So those are two new terms that you need to learn if you have not already. We also see here how long. So we're going to go through a pretty drawn out little story here about what has to happen for one heartbeat. But keep in mind, if your heart rate is 75 beats per minute, as it is with a typical average adult, all of these things that we're getting ready to talk about occur in about 0.8 seconds. So these things are pretty quick. And that 0.8 seconds can be divided up into three major parts. You have atrial systole. It's when the walls of the right and the left atria together are contracting to squeeze blood from there down into the ventricles. That lasts about 0.1 seconds, so not very long. That is followed by ventricular systole, which lasts about 0.3 seconds. And those are those thicker walls of the ventricles that have to contract with more force to squeeze blood out of the ventricles and into the pulmonary trunk and the atrium. I'm sorry, the aorta, not the atrium. That lasts about 0.3 seconds. And then the remaining 0.4 seconds is when you have total heart diastole. So both the atria and the ventricles are relaxing at the same time. So just keep that in mind. All of these events that we're talking about occur pretty quickly. Before we jump into the whole story about what has to happen for one heartbeat, let's talk for just a second about heart sounds. You may have the opportunity in lab to listen to heart sounds with a stethoscope. If you are moving on to a nursing program, no doubt you'll be learning a lot about heart sounds and how to use a stethoscope there. So I'm not going to go into a lot of detail because I am by no means an expert on heart sounds. But as you guys know, the typical heartbeat, there are two sounds associated with that. We know that, boom, 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 boom. And sometimes those are called lub for the first heart sound and dup for the second heart sound. What you're hearing when you hear that pounding, it's not the atria and the ventricles contracting like you might imagine, but rather what you're hearing are the valves closing. So the lub sound, that first sound, occurs as your AV valves close. So when your bicuspid valve, your tricuspid valve, when those close to prevent backflow of blood from the ventricles into the atria, that's what you're hearing is that first heart sound. The second sound occurs when your semilunar valves close. So when the pulmonary semilunar valve and your aortic semilunar valve close, that generates that second heart sound. Now, of course, if you're going into nursing, you're going to learn how to recognize a heart murmur sound with a stethoscope. And all a heart murmur is some type of abnormal heart sound that's usually associated with some sort of a valve malfunction. Like you may have heard before of somebody having a mitral valve prolapse. So if you think about your bicuspid valve, those two little flaps that are hanging down there from the left atrium into the left ventricle, if one of those valves gets folded upward like that, so you have one that's kind of flipped upwards, sometimes you'll have some backflow of blood from the ventricles into the atria if one of those valves is flapped over in an improper way. That's a mitral valve prolapse. You may also hear about patients that develop valve stenosis, where you have a buildup of connective tissues that have an improper consistency for the valves, makes them tougher, more fibery than they're supposed to be, so they're not quite as capable of pulling shut tightly, and that can be caused by things like inflammation, infections, especially with Streptococcus bacteria in the heart valve. So those are some things that can lead to improper heart sounds. This is a picture from your textbook, and I'm not going to spend a lot of time on this, but as it turns out, you can actually, if you place your stethoscope in strategic locations, and you can read where those strategic locations are here on this diagram or in your textbook, you can actually hear the sounds associated with a particular valve closing. So we've got the lub sound and the dup sound. The lub sound occurs as your AV valves close. The dup sound occurs as your semilunar valves close. But actually, the lub sound, when that occurs, the tricuspid valve closes a little bit sooner than the bicuspid valve. Your pulmonary semilunar valve closes a little bit sooner than your aortic semilunar valve. So there are actually 4 distinct sounds that you can detect. And what they're showing you here, for example, if you place a stethoscope in the second intercostal space, so the space in between rib number 1, rib number 2, and rib number 3, over on the right side, the right margin of the sternum, right sternal margin. When you're listening at that location, you're supposed to be able to specifically hear the closing of the aortic valve. Or as another example, the mitral valve or your bicuspid valve over on the left-hand side of the heart. If you place the stethoscope in the 5th intercostal space, so that would be between your 5th and your 6th ribs, over in line with the middle of the clavicle, according to these instructions, there, when you're listening, you're specifically hearing the closure of the mitral valve. So, and that's something I'm sure that they will teach you if you move into nursing. They're going to give you a lot better instruction on that than I can. But just be aware that there are ways of hearing the sounds associated with specific valves, and that might be important if you suspect that a patient has a valve defect. You can at least partially verify that by listening to a particular valve using those locations. Okay, so enough about heart sounds for a minute. I'm going to remind you of them, though, as we go through our little journey here of one heartbeat. So let's talk about all of the physiological events that have to occur every time we have a heartbeat. Again, this is called the cardiac cycle. Now, your heart beats continuously until you die. So we have to just kind of pick an arbitrary place to start off our heart cycle. And so we're going to pick the interval between heartbeats. And if we think about, let's look at our EKG profile again. So you guys have learned about your P wave, QRS, and then your T wave. But I'm not drawing real well today. Then you have that gap in between, and then you hit your next P wave on the EKG. So we're over in here. There's no electrical activity around the heart. The atria are relaxed. The ventricles are relaxed. So the whole heart is in diastole. Walls of the atria and the ventricles are both relaxed. Now, at this time, your AV valves are open. Your bicuspid and your tricuspid valves, they're open. Your semilunar valves are closed. They're closed when the heart is completely in diastole. During this time, you have passive filling of the ventricles. So those AV valves are open. Blood is being returned to the atria, either through the pulmonary circuit or from your systemic blood vessels via the superior vena cava and the inferior vena cava. And then that blood is able to just passively flow from there down into the ventricles based on gravity. So this is called passive filling of the ventricles, and about 80% of ventricular filling, 80% of the blood that will ultimately make its way into the ventricles with one heartbeat, occurs during this phase. Okay, but we need to squeeze out not all of the blood in the atria. Like you might have some kind of accumulating over here, over here on the sides and so forth, that's not flowing down into the ventricles all that well. So we need to squeeze that residual blood in the atria down into the ventricles to make sure they're completely filled. So to do that, we need to contract our atria. Okay, so here we go. We're going to start a new heartbeat here. You've learned already we have to generate that electrical activity around the heart to stimulate contraction, and that occurs, it's launched via the cardiac conduction system and conducted throughout all of the chambers of the heart. So first thing, as you've learned already, the SA node depolarizes. I'm going to change over to a blue here. SA node depolarizes. That depolarization wave or that impulse spreads from there towards your AV node, and then it's also going to spread across the walls of the atria, as you've learned about already. So this is the electrical activity. Let's coordinate that with what you've learned on the EKG. That electrical activity generates your P wave as that's occurring. Okay, once that happens, that stimulates, that impulse, that depolarization then spreads throughout the cardiac muscle cells or muscle fibers in both your right and your left atrium. That stimulates them to contract, so that actually triggers atrial systole, atrial contraction. And y'all remember that impulse is delayed. It spreads across the atria, but it's separated from the ventricles. You actually have connective tissue that insulates the atria from the ventricles and prevents that impulse, that depolarization wave, from spreading immediately from the atria to the ventricles. That's good because we want a delay. We don't want the atria and the ventricles contracting at the same time. If they did, you would not be able to have this nice coordinated one-way flow of blood through the heart. So we need to have all of these things working together so that the atria contract first and then the ventricles contract second. All right, we'll go back to red for blood. So as the right and the left atrium squeeze, they're squeezing out that remaining blood down here into your right and your left ventricle. This completes ventricular filling. And in an average adult, at this point, your ventricles have, in total, between them, about 120 milliliters of blood. Keep that number in mind, and also keep this phrase and abbreviation in mind, in diastolic volume, or EDV. That's going to be important. And again, that's typically about 120 milliliters in an adult. All right, so we've got all this blood down here in our ventricles, about 120 mils total between the left and the right. The blood's not doing us any good if it's just sitting down there in the ventricle, so we have got to contract the ventricles to squeeze that blood up into the pulmonary trunk from the right side so that that blood can travel to the lungs and become oxygenated. And then over on the left side, we got to squeeze that blood up into the aorta so that that nice, rich, oxygenated blood can be sent out to all of the different parts of the body. So, what's going to happen? First of all, the depolarization wave that bottlenecked over here at your AV node, it's now going to spread into that bundle of His, or His, down the bundle branches in your interventricular septum, that wall between the ventricles. And then there are branches of this that extend up into your papillary muscles, as you can see there. And then up these Purkinje fibers. Hopefully you're starting to learn about some of these things and seeing these on the models in the laboratory. And then just like with the atria, those are all parts of your cardiac conduction system, and then that depolarization wave will spread from there across the muscular walls of the ventricles. Okay? Now, where are we on our electrocardiogram? Let's draw that in for a second. So we already had our P wave just before the ventricles contracted. What we've just talked about generates that QRS wave that you see on the EKG. That is representing this spread of the electrical activity across the walls of the ventricles. Don't forget that while this is happening, your atria up here are repolarizing. Don't forget that. That's masked, even though that doesn't generate a separate wave on the EKG, because that is happening simultaneously with your ventricles depolarizing. So you don't see those as two separate movements on the EKG. Okay, so that's where we are on our EKG. That now triggers ventricular systole. So it spreads across the walls of the ventricles, the impulse of depolarization, and now those cardiac muscle cells are going to contract. That's ventricular systole. Also, let me erase this for a second. Don't forget about your papillary muscles over here. Right here and right here. Those are stimulated to contract as well. As they contract, they're pulling on your chordae tendineae, the heartstrings that are attached to your AV valve flaps. So as that happens, pulls on the valve flaps and causes them to close. So remember, when ventricular contraction occurs, it actually pulls the AV valve flaps shut. They're not open, they're shut. That's important. We want those valve flaps closed so that we don't have backflow of blood. That's what we're trying to prevent by having those valves shut. Okay, so that's when you hear your first heart sound. When those valve flaps shut, you hear the lub sound. Okay, so we're going to continue on with our story. Ventricles are contracting. Your force of contraction is greater with the ventricles than it is with the atria. Now, temporarily, you may see this run across this term. At this stage of the game, there is a period called isovolumetric contraction. So when this is happening, now your atria have relaxed, but the ventricles are contracting. But there's no change in volume of the blood in the ventricles. That's because right now your AV valves are shut and your semilunar valves are shut for a brief period of time. So even though your ventricles are squeezing, they're not pushing any blood out of the ventricles and into the pulmonary trunk or the aorta. But that just occurs for a brief period of time. But that event is called isovolumetric contraction. Iso meaning same. So even though the ventricles are contracting, the volume in the ventricles stays the same. Now, when do the semilunar valves open? As those ventricles contract, eventually that pressure builds up to the point where it exceeds the pressure in the aorta that you see there and in the pulmonary trunk, which we don't see on this diagram. When the pressure in the ventricles exceeds the pressure in the walls of those two big arteries, those semilunar valve flaps get pushed open. Blood from your right atrium is moving up that way towards the pulmonary or pulmonic semilunar valve. Pushes those valve flaps open, and now blood is able to flow into your aorta and pulmonary trunk. That blood is forced upward into the blood vessels. So we're going against gravity here, so we need a very strong contraction to force that blood in an upward direction. Okay, additional events here. What else has to happen? We're just about done with one heartbeat. Your ventricles are going to repolarize. So you got to reset all of the membranes there in your cardiac muscle cells and the cardiac conduction system. So if we go back and look at our EKG, we did our P wave, we did our QRS wave, and then your T wave is what's happening now as the ventricles repolarize. The semilunar valves, we need those to reclose. Okay, because we're finishing up this heartbeat. Now the walls of the ventricles are going to relax. They need to stop contracting. Those semilunar valves will close, and you'll hear that second heart sound when the pressure of the blood against the walls in the aorta and the pulmonary trunk, when that winds up being higher than the pressure in the walls of the ventricles, the blood starts backflowing, right? If your pressure's higher up here in the aorta, that's going to start squeezing blood back towards the ventricles. Well, we don't want the blood. We just squeezed it out of the ventricles and into the aorta or the pulmonary trunk. We don't want it backflowing. So that's where these nice little semilunar valves come in so handy. This is why they're cup-shaped, if you haven't learned that already. As the blood is backflowing from the aorta or the pulmonary trunk towards the ventricles, those little cups in the valve flaps catch that blood, and it causes them to fall backwards, and they close shut. So that prevents the backflow of the blood. All right, our ventricle walls are relaxing. We're entering ventricular diastole. We're still in aortic diastole, so we're getting back to where we started at the very beginning of this little lecture clip. And so temporarily here, there will be another isovolumetric stage, same volume. So the volume of blood in your heart chambers, atria and ventricles, is not changing because all of the valves are shut for a brief period of time. That doesn't last very long, though, because as soon as the walls of your ventricles have relaxed enough, and as soon as those papillary muscles have relaxed enough, guess what? Your bicuspid valve and your tricuspid valve flaps are going to come back open, which is going to allow blood to start flowing once again passively from the atria into the ventricles. So just before that happens, though, we have this point here during isovolumetric relaxation where the ventricles have a minimum amount of blood. Okay, so you might think, okay, well, the ventricles, they contract pretty forcefully. They should have squeezed all that blood out of there, but you know that blood's moving against gravity, and not all of it gets squeezed out. So you do, typically in an average adult, you have about 50 milliliters of blood left over. Okay, so that's called our end systolic volume. Remember, we had our end diastolic volume, about 120 to 125 mils in an average adult, about 125, which is the volume of blood at a maximum after the atria contract and squeeze the rest of that blood down into the ventricles. Okay, and again, like I just mentioned, as soon as your ventricular walls, the walls of the ventricles, have relaxed enough and those papillary muscles have relaxed enough so that those valve flaps reopen, your tricuspid and your bicuspid valve flaps open enough, passive filling of blood resumes, blood moving from the atria down into the ventricles. And that's where we are. Those are all of the events required for one single heartbeat. I am not going to go through this pretty complicated little diagram here, which is from your textbook, but it's kind of a neat little diagram. If you look closely at it, you should be able to understand everything here on this diagram, but it would probably take me 15 more minutes to go through all of this, and we've already talked about it. But look at it closely, because what they're doing in this diagram down here, this is the passage of time. You've got a timeline here on the bottom, and these are the events of one cardiac cycle. And what they're showing you here is how everything lines up time-wise. So for example, here, this lower graph, this is showing you the volume of blood in the ventricles. Here's our EDV, our end diastolic volume, about 120 to 125 mils, and where we reach that point, and then how it falls off as the ventricles contract so that you reach your end systolic volume in the ventricles, or ESV, and then how it starts going up again when passive filling of the ventricles resumes. And then on this part of the graph, they're showing you the pressure changes. Little purple line here That's pressure within the walls of the atria. This blue line, which jumps up a lot higher, is showing you pressure changes within the walls of the ventricles. Those are a lot more dramatic because the ventricles have to contract with a lot more force. And even though we didn't talk about it all that much, come on, erase. The green line here is showing you pressure changes within the aorta itself. And if you read about it, you may see there's a little blip where the pressure in the aorta starts to drop as less blood is being forced out of the ventricles, but then it jumps up for a second. That's called the dicrotic notch on that pressure representation for the walls of the aorta. That is caused when the blood falls back on the semilunar valve flaps and causes them to close. The blood rebounding off of those causes a brief jump in pressure in the walls of the aorta. So if you're actually measuring aortic pressure across a timeline here of one heart cycle, you're going to see a brief jump before it starts to decline once again. And then up here at the top, they're lining all of these things up along the timeline with the events associated with the electrocardiogram and then also the heart sound. So again, I'm not going to go through all the nitty-gritty details of this diagram, but this is a good thing to look at and make sure that you understand why all of these things line up when they do. That's important for understanding how one cardiac cycle actually occurs. All right, so I'm going to cut this video clip off here, and for the second half of this lecture, we're going to talk about cardiac output and apply some of this information that we have just discussed. So I'll be back in a few minutes.